left to log. So as usual, while we do that, I will request cameras to be on. And for the usual check-in word. How's everybody today? Apart from the heat. We've all become like the British. We only talk about the weather. Okay, all right. Good way to start. Yeah. Me too. All right. So generally upbeat. Great. So I'm going to get started because we have a fair amount to cover. And we're going to be doing communication in two sections. Today, I'm going to just go through some very basic aspects of communication in the palliative care setting. And the next session we're going to have is going to focus on specific difficult situations. And so for now, I know that there are many of you here who have trained as counselors and psychologists. So some of this might be familiar, in which case I will also request you to chime in and share your experiences or share your expertise even. Okay. So let's get going. Ashley, is my screen clear?
Yes, it's
great. Okay. So there are three aspects to communication that we're going to consider. I mean, we're not going to go into the last two in great detail this time, but when considering communication, we have to consider that it's not just with the patients and the families, it's with other healthcare providers. And today, as people who are invested in palliative care, for whatever reasons you might be invested, either personal or professional, becoming an advocate for palliative care is also a kind of communication that we need to familiarize ourselves with. What is the language around palliative care? What are the myths about it that we need to bust? And that myth-breaking exercise is something that we do not just with the public, but also with patients, with families, and with other healthcare providers. So all of this language and communication is interconnected and interlinked. So when we talk to somebody about what palliative care is, whether it's to a patient and their family and what the benefits are going to be, sometimes we need to use that same language when we're talking to other medical professionals or talking to the public at large. So we're going to talk today mainly about communicating with patients and their families. And to get things going, may I request a volunteer to please read through this first case study. So these are real cases that have been tackled. And I'm just going to use them as sort of an anchor point to get the discussion going. Anyone want to volunteer? Unmute, please, and help me out. Preferably someone who hasn't spoken before.
Yeah, hello.
Anita?
Yeah.
Go ahead, please.
Mrs. M has suffered a severe stroke. It has left her in a semi-conscious state. Her chances of recovery are not good, but it is unclear how long she will live. Her husband is her primary caregiver and is confused. They have two daughters. One lives in a different city and travels to her parents occasionally. The other lives abroad. The daughters have a difference in opinion. One wants to focus on comfort care. The other wants to spend money on intervention and more doctors. They cannot agree on how to manage the father or the patient. What are the communication challenges for you as a care provider?
Thank you. Thanks, Anita. I'm going to let this be on the screen for a few more minutes.
Yeah.
So this is a case that some of us have been involved with for a very long time.
Yeah.
This is one of the tragedies of, a situation like this where there is no real, the trajectory is very uncertain. So, I would say she's at a minimally conscious state actually. And one more thing is that the couple is quite elderly. Okay. So what are the communication challenges for you as a care provider? So what are you seeing here? What are the areas of difficulty where communication is really important as your primary tool of providing support? Just please feel free to unmute and
The
speak.
two daughters are in different places. One is abroad and one is somewhere else. So communication will be difficult.
Absolutely. Thanks, Uma. You're all welcome to use the chat box as well. You know that. Okay. What else? What else? One is that there is the daughters are in different cities.
And the daughters also have different ideas. One just wants to give him a comfort care. The other one is prepared to send money and interventions and have more doctors to treat him. So that is something, that two people have decided what to do with their father. It can be very confusing at the end of the day. What exactly are they planning to do with him?
With her, yeah. It's the mother that's unwell. Yeah, yeah. Shalaka, this is from the perspective of the treating doctor, the palliative care doctor. Not necessarily a doctor. What do you right now, as just an observer of this case, what do you see? If you want to look at it from the point of view of a palliative care provider, or even it's a free-for-all. What are your communication challenges here?
I see big challenges because I've dealt with these kind of instances, many of them. A lot of times it's about, obviously in the case of children, it's about denial. Also in the case of husband, it could be denial of a possibility that is likely to happen. There's also this thing about who loves her the most. Whoever claims to love her the most would want the most number of interventions. Usually I see in these cases the children would want interventions, but the spouse may, if he is mature enough and he sees his wife suffering, may opt for comfort care. But I think in a lot of cases, doctors also need to be a little more clear, in their communication about what is actually likely to happen. And I think palliative care is also, like I said in my very first session with you, has a marketing problem. And so in these micro events as well, there is a marketing issue here for a palliative care or a comfort care aspect to be, people don't understand what it would entail. So
you're absolutely right. Thank you, Chilaka. My network is a little bit unstable, it's saying to me. So I'm just going to turn off my video for a second. Can you hear me all right? Okay, fine. Okay, but I'll just keep my video off just for a few minutes. Okay, so definitely, and I think, okay, so since goals of caregivers are different, the preferred interventions would be different. They don't know bereavement care is part of palliative care for the husband and daughters. Father and the two daughters are not on the same page. Okay, also what Shalaka said was quite important. Sometimes it's not a competition, but it's it's a matter of proving love. Now, in this case, I can tell you that the one staying abroad is not there at the bedside and therefore feels like spending money on more interventions and doctors is the way to go. I remember in this particular case, the one who used to come down from another city, she used to obviously come down more often because she's in India. And she kept insisting that she senses that the mother is in pain. But because this is a minimally conscious lady, even the nursing team didn't think that was really a priority. They could be wrong. There was no way to gauge it. But the other daughter wanted to buy the mother an airbed, which would cost 1,25,000 rupees. So it was possibly the guilt of also not being there that led to that. And the other thing, so that led to even more conflict because then the sister living in India said, instead of spending it on an airbed, which she doesn't really need at this point, why don't you help me buy my flight tickets? Delhi to the south of India every couple of months. So she was feeling that kind of strain because she was in the country, she was coming down more often and so on and so forth. Okay, so there are several challenges, as some of you have pointed out. There is no consensus amongst the daughters. The father is confused. He's not quite clear what's happening. There is a little bit of a power struggle going on about who gets to make the decisions and what is a priority. And they cannot arrive on any shared goals of care for the mother. Okay, so there are several things that are happening here. Now, if there was an advance directive, it would have helped tremendously. Yeah, absolutely. Bang on, Aparna. Okay, so this is one case study. I'm not here to ask you for any solutions to it right now. I'm just asking you to draw out what you think some of the pain points here are. Okay, may I have another volunteer? This is another case that is a real life case. Would anyone else like to volunteer and read this case out?
I'll do it.
Yeah, go ahead. Go ahead, Indra.
Mr. J has been diagnosed with an aggressive and advanced form of cancer. He retains functionality and is not in pain. His wife was a dentist and is deeply religious. She believes prayer will cure him. Their only daughter works and lives abroad and is now visiting. She understands that his time is limited and she would like to speak with him about his wishes before she heads back. She doesn't know if she will get the chance again, but her mother doesn't want her to and stands guard over the father. The daughter is distressed that her father knows about his prognosis, but is not being given permission to acknowledge it and get his affairs in order. What are the communication challenges for you as a care provider?
Thank you, Indra. So another real life case, and I would say that this is a fairly common situation where one person in the family becomes the gatekeeper and doesn't allow for an honest conversation to be had. Okay, so what would you want to tackle here first? What do you think is the most important thing to tackle here?
I think his wife should realize and give it a thought, saying she has to accept that he will not be staying for long. I think that's why she's trying to protect him from the daughter. She doesn't want to accept death of her husband because she feels that her power of prayer will work for him.
So there's one more thing there at stake, huh? Her faith.
Yeah. Her faith, yeah, right.
Her faith is also at stake there.
Yeah, definitely.
So if you start acknowledging that death is imminent, then faith becomes a secondary issue here. Yeah. That's a very tough one. People they don't easily give up that.
Yeah.
The second thing, what you said that the mother needs to realize. How do we get the mother to realize? How do we facilitate that? Yeah.
See, the mother has only one thing in her. She believes that prayer will cure him. So it's very difficult to make her understand, even though she's a doctor, she should be able to realize, but acceptance is not there. So she will never allow, anyone to come in the way, is what I feel.
That's right. But okay, so here's one thing. Shalaka, please.
Yeah, I think the mother should be allowed to continue with her approach, which is prayers. And the daughter should be allowed to, allow him to put his affairs into order. I think both can run parallelly. It's okay to do those kind of, tying up loose ends. Worst case scenario, everything is already in place, so you'll have a peaceful exit. Best case scenario, he is cured and he already has everything else worked out.
Okay. So he's not surviving this, I'll tell you that. There's also a problem of time sensitivity. The daughter has to go back. She has a job. She cannot be here indefinitely. So there's also a bit of a, urgency there. Yeah, Darshana, please go ahead.
I think there is a failure to acknowledge the most important stakeholder here, who's the patient. And I feel he should be given the agency to make the decision for himself. I feel like often the onus is on the caregiver, either the daughter or the wife, to make a decision for him. But I think from a palliative care provider perspective, if they can kind of bring in that perspective that he still has that agency to make decisions over his life despite being in this state, I feel like that will be a very valuable perspective to add.
That I 100% agree with you. Now, we're discussing some tricky things: autonomy, agency, all of that. Also understand he's allowed his wife to be the gatekeeper. Okay, it's not that he doesn't know. There's nothing stopping him from going and having a conversation with the daughter. But the father is allowing the mother to gatekeep. Now, there is a dynamic there also. She's his primary caregiver. Okay.
Smriti, may I add here, since she
Yes.
is deeply religious and she believes in prayer, would it be a sensible or possibly an idea to involve the priest and get him to talk to the mother?
You could try that. Before that, you have to sensitize the priest in palliative care decision making. Okay. What I would say is the first person here, and this is actually what we did, is we tried to elicit the mother's fears. Rather than forcing my opinion or our opinion and saying, listen, your daughter has very little time with her father. She needs to resolve this. He also needs to resolve it. Yes, we can continue to pray, but we need to have this conversation. The more you push that narrative, the more she'll push back. People tend to dig their feet in when their core values are being threatened or they're perceiving it as a threat, right? So here, she's convinced prayer will heal him. In spite of, see, another thing, she's a doctor. How can there be this irrational sort of incongruence in her thinking? But very often that goes hand in hand. I mean, that happens a lot. And in this case, the faith part is winning out. So if I can't push her in a particular direction, I have to draw her out. Okay. So instead of saying, okay, I mean, everything that all of you have said is absolutely 100% correct. But in this case, she is the one that is controlling the power dynamics. She is the one controlling the channel of communication and which way it's going to go. So I need to first sit down with her and say, what about this conversation is worrying you? What kind of a conversation do you not want your daughter to have with your husband? And let her tell you. Because behind anger, behind defensiveness is always usually a fear. What is her fear? Here is a woman who is losing her spouse. Her daughter does not live in the same country. By accepting his mortality, she is accepting that she's going to be alone for the rest of her life. Then we talk about, building her own coping strategies around that. Who are other sources of strength to her? How has she handled things like this in the past? Okay, I'm not like this. Obviously, she's never been in this situation, but in times of difficulty, who does she turn to? Now, what does she hope for her relationship with her daughter? Because at the end of the day, if the daughter and the mother go at loggerheads now, chances are they will have a very estranged relationship after this. Okay, so we also need to make her realize that your daughter is here. And what kind of a relationship do you hope to have with your daughter? So those are just some of the aspects that we would bring in. And I would just say that eliciting her fears would be a very important thing to do, because that's really going to give you a clue as to why she's being a gatekeeper. Okay, I'm not going to go into this in too much detail. This is just sort of to introduce you to some of the scenarios that we see quite often, because very often people say oh, palliative care, so the communication is about death and dying, right? It's not. Sometimes it's about stuff like this. It's conflict resolution in the family. How do you encourage somebody to take agency for themselves? In India, we don't have the kind of individual autonomy that we'd like to believe that the Westerners, the Western framework talks about, because here we are relational autonomy. We usually work in groups, in families. Families take decisions for one another. It's not the kind of individual autonomy that we see emphasized on in the West. Okay, all right. So the single biggest problem in communication is the illusion that it has taken place. I might believe that I am a very articulate person and I have said something to the best of my, ability. And I'll come back to you 5 minutes later and you haven't understood anything I've said. But I'm doing a communications class. Surely you understood what I'm saying. Okay. But this is a problem. So this is where we're really going to try and figure what makes for effective communication so that what I'm saying to you is received by you in the way that I mean for you to receive it. Okay. All right. So why are we talking about communication in palliative care? So why communication? This is a question for all of you. Why? Why is communication such an important part of what we're trying to do here? And I'll start you off. Number one, good communication can help you establish trust and rapport with whoever you're talking with, whether it's the caregiver, whether it's the care recipient, whoever it might be. Okay. Communication enables you to elicit concerns. It helps you provide information. It allows you to plan the treatment. Very importantly, it is how you will discuss prognosis. Where is this illness going? What are the expectations? How is it to be managed? So on and so forth. And once you have discussed prognosis, also establishing goals of care remember in our assessment session, assessment is an ongoing, it's an ongoing process. So we will establish goals of care after every session. Have those goals changed? Has anything changed for the person? Has anything changed in the disease? And therefore the goals have to change according to that. So all of those things need to also be discussed. Like we saw in these examples, it helps to resolve confusion and conflict, and also to provide emotional support. Now, all of these things that I've put on your screen right now seem like very obvious things, extremely obvious things. But then when we try and break down each one of these, it becomes a little bit complex, a little bit more complex. I wouldn't say complex, but it takes a little bit of getting used to and building some skill around it. Okay, now some considerations. Who is communicating? Sorry. Who is communicating? Like we've discussed in a previous session, the main caregiver may not be the decision maker. Ashley, can you please connect with Premi on the side?
Yeah, ma'am, sure.
Yeah. Who is communicating? What are we communicating? And how are we communicating? Okay, so each of these aspects have different considerations as well. Are we discussing treatment? Are we discussing concerns? Are we discussing challenges? Who are we talking to? Well, we talked about the fact that sometimes it's the person who controls the finances who's controlling all the decisions. More often than not, it is that person. Okay, and how are we communicating? Verbal, non-verbal, through written documents, through information pamphlets, and what are we doing? How are we doing it? Okay, now, just very quickly, I want to introduce you to the idea of levels of clinical decision making. It's just to clarify a particular concept, not anything too complex. Now, there is just sometimes the information given. Now you have to make a decision about care of your loved one. Okay? And typically what happens is there are different levels of information you're working with. One is just medical, which is just information. So-and-so has cancer of the prostate. Third stage, third grade, whatever it's the grading, the staging, whatever it meant. It could be something else. So the person has had a stroke. So this is what it means. There's been this kind of a bleed. This is the part of the body that is affected. And this is the treatment that is going to be given. There's another kind. which is paternalistic, where I will give you information and recommendations. This is what has happened. This is the part of the body that is affected. These are the treatments available to you. Okay? My paternalistic approach might be, this is what has happened, this is what is affected, these are the treatments available to you. This is what I recommend amongst those treatments, because these are the statistics in favor of successful outcomes, etc., etc., etc. So I'm giving you recommendations along with the information. And typically, it's this paternalistic approach that we see most often. The third kind is shared decision-making, where I give you the information, I give you the recommendation, and then I elicit your values and preferences. This is what has happened. This is the part of the body affected. This is the treatment option. This is what I recommend amongst the 4 treatment options. But tell me, is this what you want for yourself? What is important to you? This is the treatment option, but it's going to take you 8 rounds of chemotherapy. Each chemotherapy is going to cost this much. It's going to mean that you have so many days in the hospital with side effects. It means fatigue. It means this, this, this. The other option is radiation. The other option is this. Now, what is important to you? What is the way you'd like us to go forward? I'll turn around and say, listen, if I'm already in 4th stage cancer, maybe I don't want chemotherapy that's going to cost my family so much. I would rather, do this treatment. It keeps me comfortable and I want to be at home and I want that money to not be wasted on treatment that is going to be futile. Or I might say, okay, that sounds good. And you're saying that, the response rate is great. It means this much cost. Okay, fine. So I will probably have to take a loan to do it. But yeah, I think we'll go for that. Because it allows me it allows me a better shot at longevity. So this is the kind of communication and clinical decision-making we're aspiring to. Okay. And unfortunately, do you think it happens often? How many of you have experienced shared decision-making in your experience with healthcare?
There is so much of uncertainty in the treatment.
Mm-hmm.
You don't know whether you will be able to, have some basic life after that, or would it be bedbound and you still be suffering for the next few years?
Yeah, it's not easy. And the thing is, I can give you this information. You can get this information from the internet. Okay, this medical information. And my doctors are very busy doctors. They don't have time. Recommendations, yes, because also recommendations come as a result of their own experience and expertise and what has worked for them and what is also within the capacity of that particular hospital. Now, to really sit with shared decision-making means I have to really spend time with you, get to know your story, get to know what's important to you, your priorities, your concerns, and that's going to take some time. Okay, yes, Aparna, you have your hand raised.
Yeah, I was actually just about to say about the time factor itself. Many a times, like even when I used to be there in daycare centers and all, doctors at the moment, they don't have the time to explain everything. And for the patients and the family members, it can be that their previous doctor only gave them the medical information. And when this new doctor is giving, let's say, a bit the paternalistic information, a huge chunk of that information is new to them. So it's like, even if they had this information before, there is like a new layer of knowledge that they need to process. And because there is, it's not like they have to just learn it for an exam. It impacts their life to such a great extent. The emotional processing of that information also takes a lot of time. And many a times when doctors ask, like, what do you want your treatment to be? The patients and the family members, they don't get the time to emotionally process the information and come to a decision. So it's like, basically, like, even the patients and the family members, they don't get the time to make, like, to think clearly about what they want to do, whether their priority lies in comfort or their priority lies in longevity. They don't get the time to think, to come to a conclusion.
And why do you think they don't have the time to process this emotion?
Well, as far as I've seen, as it is, the doctors don't get time to sit with the patient. That's where a lot of psychologists do come handy, to have that conversation with the family members and the patients. But then there aren't many who are trained in this sort of a conversation. Let's say something as simple as bad news breaking, where the family members, they don't tell the patient, but they would prefer professionals handling it. And even I think it was a Ramu's example that we did couple of sessions back, where Ramu was just being sent to one institution after the other, but nobody was actually listening. So I think it's like incoherence in the system itself, where a lot of time just goes away in giving factual information, let alone the emotional processing part of it.
No, you're absolutely right. I appreciate that perspective very much. Now, I remember someone asking Dr. Rajgopal the same question. Firdaus, I'll just come to you in a minute. So Dr. Raj was asked this question saying, you palliative care doctors have all this time, but in our hospitals, we don't really have the time to do all of this. Simple question. You're walking past a patient, you realize that the patient is choking and whatever, and they need a tracheostomy put in. You'll do it. It'll take you 20 minutes to do it. Why will you do it?
When the suffering is visual, it's more, people are more tempted to take a step forward.
Also, it's a life-saving intervention. We need to start thinking of good communication as a life-saving intervention. Because if I spend that extra 15 minutes with my patient now, it will probably save my patient 5 unnecessary hospital visits, which is also, by the way, a burden on my time. So this loop of doctors not having enough time to have a conversation, half the patients in their unit are people who've not understood them the first time. So I would say that this is another big reason for communication to be a constant upgrading of skill sets that doctors and all of us in healthcare have to do. If we have to go for continuous medical education, if that's a part of our career path, we have to also incorporate these skills. And unfortunately, this is not seen as the case. Now, I'll give you another example before going to Firdaus, which is there's an incredible oncologist in Cochin. I consider him one of the most exquisitely trained and well, in terms of communication, one of the most clear-sighted and articulate communicators I know. He doesn't spend like 1 hour talking to the patient, but he's honed his skill set to the level where in half an hour, he's able to actually give the patient the information they need and elicit their concerns. He said something very interesting to me. He said, Smriti, I try and do as much as we oncologists believe in doing a biopsy, I believe in doing a wallet biopsy. I said, what is that? He said, I want to know what they are capable of financially, so that we're not going down this path for 8 months and then they're broke. And that treatment is now not effective. Now they have to switch over to something else. And it's not that if they don't have the money, I'm going to give them suboptimum care. I'm going to give them the best care within what they can financially afford also. And I love that it came from a doctor. He said it's a wallet biopsy. And if I have to be an effective doctor, I have to be able to do that. And I have sat with him on many consultations with families that I referred to him. I can guarantee you our conversation doesn't last more than 20 minutes. So it is possible. What I'm trying to say is it is possible. Yeah, sorry, Firdaus, we've kept you waiting.
So I was just, so I work at a out of hospital care center. So palliative care discussions are like a normative, like it happens every day basis. So when you're talking about not having time from the doctor's perspective, we've seen it all. And I think it is just a self-awareness where the doctors needs to imbibe. And in a center like this, we also have a special meetings wherein the doctors are, in fact, given classes on how to actually be self-aware about how sensitive can you actually speak to a patient's family, and you don't have to spend a lot of time in actually giving in your inputs. It hardly takes 5 to 10 minutes or 15 minutes maximum, but that is a change over. I mean, it's a game changer. But it just a self-realization. The moment we think that we do not have time, that itself is a block.
Yeah.
But we're able to do, we're able to do here at our care center. We're able to give that much of time. And I see that difference. Even if it is a terminally ill patient who comes to us and we're giving that ample amount of time from the different therapists, we all sit together in one room. We fix an appointment, fix for 15 minutes. We have a lot of family members who are staying abroad. We join them on Zoom meeting or G Meet. We have a talk for 15-20 minutes. It's like an open brainstorming session. And then they
Sorry.
they sorted out as to what needs to be done. Because there's an effective communication from both the ends.
Yes, absolutely. And yeah, that's so, I mean, I'm so
Yeah.
heartened
So I
to
think it's very
hear that. Yeah.
essential.
Yeah, go on.
Yeah, I think it's the first time that you have meet this family and the patient is when you need to sensitize this issue that we need to be very how the communication is happening between us and you. And that's when you get into the comfort zone.
Absolutely. Absolutely. And I think to that point, like Darshana has talked about the fact that the doctors are trying to avoid a situation where the family points fingers at them. Now, that would not happen if the family was able to earn the trust. I mean, the doctor is able to earn the trust of the family. And that happens through communication. Now, again, it's a loop. Okay, I'll stick to the facts. And how will I stick to the facts? We're going to talk about that in a little while. I'll tell you, I was once at I won't name any names, but I was once at this place where a doctor stood up and said, I've explained this to this patient 10 times. Now he's come back one more time to ask me. And I'm thinking, why did it take 10 times? It's because they'll use words like metastasized. They'll use the jargon. Right? Now, and then you say, got it? Okay. Yeah. And they're like, yeah, because there is also an inherent power dynamic. You enter the healthcare system when you're vulnerable. There is an inherent power dynamic, and there is a fear of questioning as well, right? Now, I would say if a person hasn't understood you 3, 4, 5 times, you need to start introspecting as to why they're not understanding you. Are you not speaking to them in their cultural context, in their language, in simple English? Are you speaking to them in your medically acquired Greek and Latin? So that needs to be observed as well. And, I think I've mentioned this before. When my mother was diagnosed with idiopathic interstitial lung disease, I looked it up. I thought I kind of understood it, till a very good doctor sat with me and explained to me the idea of honeycombing and how the disease, and she said it quite beautifully. She said, it goes from like soap bubbles to gel to like cardboard to like honeycombs. That's the progression of the lung. And I got it. I understood what the disease finally meant and why this kind of support was needed, why this kind of support was needed. That conversation took, and my brother lives abroad, I live in India. We sat and had this Zoom call for 45 minutes. We've never had to have that conversation again because we knew exactly what was going on. And it wasn't me then having to, do Chinese whispers and tell my brother. It took that little bit of time, but that saved us having that same conversation again several times. Okay. So anyway, in the interest of time, because I'm notorious. Sorry, Shalak.
No, it's okay. If there's not enough time, go ahead. Sorry.
No. I'll no, I'm sure we can.
I was just going to, you just mentioned your mother's case, and I hope you all went for palliative care for something like IPF or IID. Did you all? Did you go for palliative care?
Only did palliative. I took care of her at home because we had that conversation. So the first doctor who I went to very clearly said, yeah, she's got this. Just be prepared for lots of hospital admissions. That was it. I said,
Okay.
what? So every time she has an exacerbation, you bring her to the hospital. I said, you want me to bring this woman who can barely walk to the hospital? Then I had this conversation with Rajni Bhatt, and she said, we will take care of her at home. My mother didn't have a single hospital admission in 5 months. She died at home. I took care of her at home. She died at home. We got her the best care. And every time there was an exacerbation, we were able to handle it because we were prepared for it.
This is how it's meant to be handled. I'm part of a group of around 275 ILD patients, mostly from Western India. And just the other day, I asked them a question, who here has been prescribed palliative care and who has started it, and where are you all doing it? Not a single person has started palliative care. All ILD patients, all end of life, at the end of life stage, all at very high LPM O2 concentrations, as in supplemental O2 needed, and not one of them has started it. So,
Yeah,
I mean,
but
this is 50% of those patients are in Bombay, to even say, and they are those from a slightly middle class, upper middle class families, and these are the patients not going for palliative care.
But this says everything we need to know. I mean, I will come back to, I mean, thank you for sharing that. And I will tell you a little bit more about the journey as we go along, but thank you for that. And I will say that I've been trained in having conversations in end of life care and all of that. I've been in palliative care for 23 years. And still I found this particular thing extremely difficult because it's a whole other kettle of fish in that sense. Okay, sorry, I'm just going to move ahead. Now, there are other considerations and important communication milestones, okay? At the time of diagnosis, clear understanding by everybody. We just talked about that. Have I understood what ILD means? Has my brother understood it in the same way? Okay, potential trajectories. Now, while one doctor said to me, yes, be prepared for multiple hospital visits, he didn't tell me what that looked like, what an exacerbation was going to look like. But then when I spoke with Rajni Bhatt, she said, this is what it will look like. This is what an exacerbation is going to look like. As you go with every exacerbation, the next one's going to be worse. Oxygen levels are going to be worse. So this is what you need to do to prepare. At this point is when we'll bring morphine in to support with the breathlessness. At this point is where we'll need this. So we laid out the territory, and she said, also, you need to know that the next exacerbation can be the last. So I was prepared by, I mean, I'm very lucky and privileged because I have access to all these incredible doctors, but it took that kind of preparation. And they didn't assume that just because I'm a palliative care provider, I will understand automatically. They sat with me and said, do you understand what we're saying to you? This is a terminal disease. Yes. Do you understand that even though we say every exacerbation will be worse, the next one can be the last? You know what that means? Yes. So it was very, 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 and these are not conversations we had once or twice. We had them several times. Okay. Levels of acceptance. I accepted it right up because, again, I suppose because of my palliative care training. I had cousins, because my mother was the matriarch of my family, the last living elder. I had cousins telling me, she was 76 when she died, can we still go and try for a lung transplant? And I said, I don't think, I want to put her through that. Nini, why don't you just move her to Delhi? We'll take care of everything. I mean, the levels of acceptance really varied. And what is difficult at that point also as a caregiver is to juggle everybody's opinions. Everyone from your neighbor to your uncle to your friend's cousin who works in some clinic somewhere, they all have an opinion. And it is very, very, I think one of the most exhausting things for a caregiver is to have to juggle everybody's opinion and say over and over again, no, we've tried this. No, we've decided to go for this. So finally, at some point, we had to take charge and say, my brother and I are the primary decision makers here, with my mother's, obviously with discussions with her and so on. Now, at the time of treatment, understanding the effectiveness and implication. What are the pros and cons? Okay, this medication is going to help with your breathing, but it might make you sleepy. This medication might take care of your pain, but it might give you a little bit of constipation. This, what does that mean? What are your activities that you will be able to do? Assessing treatment impact on the disease, patient and family. Please remember, not just the impact of the medicine and treatment on the disease, but its impact on the patient and the family. What does this mean? So we're going to, I think I've mentioned I was adopted by my Masi. So she raised me. She died of cancer. And then last year I lost my birth mom. Now, the difference in both cases was quite vast. But in this case, because it was very paternalistic. We didn't have any choice in the treatment options. The oncologist told us what to do. We did it questioningly. And they would tell us, okay, nuclear treatment, we did that. They never told us what the side effect was going to be. We didn't know to ask the questions either, okay? In this case, again, 23 years apart and lots of palliative care training apart, but we were able to assess, okay, this medicine is going to take care of, it's going to slow down the deterioration. What does that mean for quality of life? She's going to be able to walk around with an oxygen concentrator dragging behind her for the next 2 months. After that, she's going to be confined to a bed and you're going to need oxygen cylinders. My mother was a chain smoker, so it meant that she can't smoke anymore. And of course, that was a big one. And at some point, I had to tell her, if you light a cigarette, the whole house will explode because we've got oxygen cylinders at home. But what did it mean for us? It meant I had to shift to Allahabad for 6 months and live there and take care of her because she needed 24-hour support. So when we talk about disease and treatment, we have to not just see how it impacts your molecular, cellular, tissue level. You have to see how it affects the person, how their perspective of life has changed. The day my mother shifted to a wheelchair is the day she lost heart because she said, oh, this is it. To her, that was the transition point. So what is acceptable to some people will not be acceptable to others. There will come a point where something will break their spirit. What is it? We don't know what it'll be. Using a wheelchair. In some cases, it's not being able to go to the toilet by yourself, So what it means to the person. And so all of these considerations have to be taken into account when you are having these communications along the trajectory of the diagnosis, the treatment, and the prognosis. And like Matthew, my friend, the oncologist, says, affordability in the long run. Is it sustainable or is it going to financially destroy the family? That is an ethical question that needs to be answered. Okay. Now, prognosis. Prognosis is bad, or prognosis is that it's indefinite. We don't know. What are the goals of care and what is acceptable to the person? Okay, it is acceptable to me to have somebody else bathe me and feed me, as long as I'm able to sit up and talk to my grandchildren when they visit. Those trade-offs are happening. This is acceptable to me. It is acceptable to me to not have too many visitors at home because of an infection risk. It's acceptable to me to see fewer people. It's acceptable to me to give up certain kinds of food or something else, right? What are those goals of care and what do I want to be able to do in return for this? Yeah, Narmada?
It's a really quick question, but when you bring up affordability in the long run, I've noticed that especially when you go to a multi-specialty hospital, it's the doctor who handles the conversation about treatment plans, and it is often paternalistic. And then payment is often in the end, or it's an advance, or you go to a separate department for it. Very often, if it's a big hospital, one primary caregiver, they're walking around the whole building trying to navigate all of it. How do you integrate it when someone is in a difficult position financially and they're trying to navigate different forms of treatment? Doctors often say, I don't know. I don't know how much this costs, or I'm not able to give you estimates on it. So this person is just like shuffling back, and in that whole process, they end up feeling guilty, right? They're like, oh, I'm not doing enough. Who mediates?
Yeah, sorry.
No, I'm done. Go ahead, please.
No, so there are no easy answers to this. And our system is geared in this way. I completely understand that. Very often doctors will say, that's not, I don't know how much it's going to cost. I can only tell you how effective it is. Which is why our healthcare system today is in the condition that it is. 55 million Indians below the poverty line every year. So I'm not saying that, I mean, what we are talking about here are probably very utopian and ideal situations. But I think each one of us, to have this named, that these are conversations that we should be having, is one step. Now, there's now a massive trust deficit between the healthcare system and the end user. There's a lot of anger, and there's a lot of contempt also, you know, but we've gone from being the healthcare service to the healthcare industry. And, you know, so this is what you've described is very much a signature of this whole thing. How do you help somebody navigate this? Like I said, a conversation with, and Arjun Matthew is not a palliative care physician. I just want to clarify that. He's a medical oncologist. I would say it goes back to training. This is the kind of stuff that doctors need to be trained in. They don't have the training. So 2019 is when you brought in 8Com into the medical curriculum of India. 8Com is attitude, ethics, communication. It's come into the undergraduate medical curriculum of India in 2019. You are not going to see the fruition of it for another few years. How do I have a conversation with somebody about how much their care is going to cost them? I don't know how to do it. Today, some of us are having this conversation for the first time. Today, some of you are hearing the phrase shared decision-making for the first time. Today, there are some possibilities that are, you know, that we probably didn't consider earlier. So anyway, I think this is a way of all of us, you know, learning together. Hopefully, with the introduction into the medical undergraduate curriculum and these elements coming in, maybe the next generation of doctors is going to be able to have that conversation with a lot more ease than our current lot. I don't know. A lot of it is I mean, I've seen some fantastically successful doctors having this conversation in the busiest of, you know, OPDs. But it's taken years of practice to bring it to this art form. So I'm sorry, I have not given you any solutions, but thank you for highlighting that is the reality. It is true. That is the reality. Okay, coming back to this, when to stop treatment is a very, very, very difficult one. Not all of us are going to have that conversation, because stopping treatment means giving up, which means, you know, there's a lot of negative narrative around that. And it's very unfortunate, because we don't give our loved ones the option to stop treatment, even if they want to, because we insist that they fight and they don't give up. But oftentimes the measure for that is when it is hurting you more than it is helping you. When it's the benefits are not outweighing the negative impact of those treatments. So maybe we don't stop treatment. I think the problem also is that the usage of that phrase, let's stop treatment. We're not stopping treatment. We're stopping certain interventions. Okay. We are cutting back on that which is not being very helpful. We're increasing more comfort care. Like, that's probably the conversation to be had. Where do you want to be taken care of? Care location options. At home, in a hospital, in a in a long-term facility, somewhere where you can be closer to healthcare. I live in the middle of the jungle, so if I'm ever sick, then I'm going to have to think about where to be. But those are also conversations. Who's going to be with you? Who in your family is going to quit their job to stay at home? Okay. So, or people sometimes choose, a lot of the times I see, and it's poignant and sad also, but elderly parents are taken to where the kids live because it's easier for the children. And of course, it's done out of love. But sometimes that's the worst thing that can happen because you're being taken out of your comfort zone and you become a guest in your child's house. So that itself has cut down your autonomy by 50%. So these are difficult choices, but all of these are considerations to, to have along the way. Okay. Now, this one is an important one. Who decides? Who decides? Does the patient decide? That is, provided they have all the information and, very importantly, decision-making capacity. We'll talk about this in a minute, so hold that thought. The patient decides. Who decides? My son will tell you what to do. You talk to my son. You talk to my husband. In the case of Mr. J, his wife was a dentist. So he's probably asked for her to also be the liaison with the healthcare system. My uncle will be the one because he's an orthopedic specialist. But he's part of the healthcare system now. So, I mean, this has happened. On how many occasions has this happened? Okay, patient will decide, who will decide, and conversations to be had in advance, preferably when healthy, if not at least when lucid. This is part of, we've talked about the living will, which is the advanced medical directive, which is the document, but that is part of a larger thing called advanced care planning. Advanced care planning is the overarching philosophy. Advanced medical directive is the document that brings it to life. Now, even that conversation is so important. If I tell my husband, if I'm not able to make decisions for myself, I'd like you to make decisions for me, but please understand something. I don't want to be on a ventilator. I'm making that very clear to you right now. You will not put me on a ventilator. I do not want to be resuscitated. I want to be an organ donor. Please don't, whatever happens, please don't put me in that one particular corporate hospital because I've had a bad experience there before. So, but those are conversations to have in advance. Because once you're sick, that conversation becomes volatile and emotional, and it's not a conversation to be had when your emotionality is high. Okay? And if not healthy, at least when lucid. Person is already sick. You need to sit down and have a calm conversation when that person is lucid. Okay, lucid meaning clear in the head. They know what they're saying. They're aware of their surroundings. They know what is going on, and you have that conversation. Last one, family decides. There are three options. Either the family decides, okay, or there is no discussion, or no one decides. Doctor, we'll do whatever you tell us to do. Sometimes what happens is the doctor will ask for your preference, but we'll say, no, you tell us, you do what is best. I've had patients ask doctors, what will you do if this is your mother? How many healthcare providers have the communication skills to answer that question? Okay, so I'm asking you all just now. I'm going to go and get treatment for my mother. I've come to you and you ask me for my preferences. And I say, no, what do I know? I don't know anything about medical science. You are the expert. You tell me what to do. And you try to have a conversation with me. And finally, I tell you, okay, but what will you do if she's your mother? So how are you guys going to respond to that? What is your response going to be? The tricky one, huh? What's your response going to be?
No, I'd say every patient is different, and every patient's desires and needs are different. The family's desires and needs are different, and
but that's okay, Shalaka. But I want to know, what would you do in my position? Now, you know now.
Yeah, I mean,
I
think
my case,
if I can, sorry, you were saying?
I said, you know my case. I know every patient is different, but you know my case. You're handling my case. So you only tell me, what would you do?
Yeah, I mean, if I was working as a palliative care professional in this scenario, I would honestly say, yeah, if it's my mother and she needed comfort care, I would recommend comfort care. Why not? And I would explain why. I would give, because now the conversation has been personalized, I would, if possible with me at that point in time, I would offer some personal context to it. Why that? And, maybe that contextualizing and that rationalizing may help the person understand and, make sense out of it and try to relate it to their current situation.
Okay, all right.
Smriti, if I can offer you one thing, I'm actually a patient myself, not ILD, another pulmonary condition, and so when I deal with patients, and sometimes they don't know that I'm a patient myself, and when I have these difficult conversations, it's often, oh, I get asked this, what would you do, because they don't know, they think I'm a medical professional, or or an adjunct professional in that context. And then it's only when I say, hey, I'm a patient myself, and I'm going through the same things, and I'm going through the same considerations and the same emotional impact, is when they actually stop to question me, and to they start believing in what options I'm giving them, what kind of contextualizing I'm doing for them, why I'm saying what I'm saying. But I think sometimes it helps to establish, where I'm coming from, even as a professional, and why I'm saying certain things. And maybe, that time needs to be taken to bring all of those things together for that family to understand why it is important. Maybe sometimes personalizing is the way to go for it.
So I believe that there is a place for vulnerability, and that is why it's really important for people with lived experience to be in the space. We're doing a lot of also, I mean, I do know about your background actually, and I think that patient advocacy is one of the most powerful things now, because you need, so there's this beautiful quote by Arundhati Roy. She says, there's no such thing as the voiceless, only people who are preferably unheard or deliberately silenced. Now, we don't often want to hear the patient's perspective because it somehow takes away the science. But the fact is today, this is the kind of connection that actually also builds trust. Now, I'm going to come back to this question that I asked you. What I would ask this person is, tell me more about your mother. It's not about me. It's not about what I would do for my mother. We need to refocus on the person for whom decisions are being made. Now, I could say, boss, my mother, all she wanted to do was light a cigarette. So we're not doing what I would do for my mother, which is have a fight with her about that. I need to know who your mother is. Tell me more about her. Tell me. And in the course of that conversation, try and elicit from the person, okay, this is actually not something that my mother would have liked. My mother values her independence. These are things. My mother likes to cook. She likes to do this. She likes to do that. So slowly, I'm getting a sense of what the mother is, who she is. And then my recommendations would probably be in line with that. So shift the focus. When the question is asked to you, what would you do? Ask about the person who we're making this decision for. Okay? Stories. Get their stories. Get to know them better. All right. Sorry, I'm just going to rush through a little bit, because if I don't do this, then the tech team is going to be very upset with me. Okay. Family decides sometimes where the patient has absolutely no say. Sometimes there's no discussion. It's a family that doesn't like to talk to one another. They never make decisions together. They're all estranged from one another. So there's disarray. Nobody makes a decision. And no one decides. So patients' wishes and preferences are not considered. It's always an emotionally charged situation. Somebody's always fighting with somebody else. And decisions are made during a crisis. And invariably, someone will come back and say, that was a bad decision. Then there'll be some blame game and all of that stuff. So if somebody comes to you and says, I'm not going to decide, you decide, we have to get the family to take ownership. Okay? Because no good thing comes out of the family handing over entire reins to you. Of course, there is the power dynamic in a lot of places where that's what the family wants, and the God complex is there to protect the healthcare providers. But ideally, this is not what we want for ourselves or our patients. Okay, sorry. Where is the location of care? Also an important decision. Hospital, home, or hospice, nursing home, assisted living. Now, hospital is usually ideal when what is needed is acute care, procedural interventions, close monitoring of symptoms, and also affordability. A nursing home or hospice or assisted living makes sense when it's extended care and the family's capacity to provide care. I need to go out and I need to work so I can come back and pay the medical bills. I'm the sole caregiver. So even nursing home or hospice, these are not permanent. Please understand, these are not permanent placements, okay? Sometimes there's respite care for the caregiver. Sometimes they'll be in the hospice for a few days, stabilize, and then come back home. So it depends on what the situation is for the family. Home is, you need to consider access to support. Do I have access to medical opinion? Do I have access to a support system? Now, for me, in my case, and again, I'm using my case, is that when I spoke with the doctors and they talked about the trajectory, one of the things we were worried about is that the way the hospital system was geared was that if she did have an exacerbation, they would have ventilated her. And in fact, one of the doctors there at Allahabad said, Smriti, please don't bring her to my hospital or any hospital because you will lose control of all outcomes. She will leave the hospital only once she's dead and she's died of a cardiac arrest. Otherwise, it's not going to happen. So, but again, I was lucky to have access to doctors on call, etc. And I also had the ability to, I had the ability to work from home. Right. So that was a big one. So those circumstances helped. And I did have some amount of support in terms of people coming to assist with, or family coming to assist with various things. So these are decisions, but also that need to be made, because for some people, they want to be at home. They want to be taken care of. But what happens is there's that fear that people will not be able to take care of them at home, or the helplessness of the family. Now, again, one of the good things about palliative care is that it empowers the caregiver. Not every crisis requires a hospital visit. These are things that you can manage at home. So in our case, we were taught how to do non-pharmacological ways of upping the O2, which is, something called pursed lip breathing. Things like that, which automatically starts bringing the O2 levels up, just fanning of the face, things like that. How do we increase oxygen supply before we move her to the portable toilet, rather than wait for her oxygen to drop and then have a panic attack? So all of those things we were taught how to do, and we were able to do it at home. Okay. Now, communication, why is it difficult or often ineffective? There are many barriers. Sometimes there are professional barriers from my side, from the hospital side itself, or from the healthcare system side. One, fear of the patient's reaction. I'm giving them bad news. I'm scared of how they're going to react. It's going to be unpleasant. Okay, so I will stick to just the facts. I will stick to jargon. I will only talk to them in medical language, and then I'll disappear. Okay. I don't really know what to say. What will you do if this is your mother? I don't know. I've never had that conversation. I've never been in that situation where my mother has needed this, right? Or I don't know how to respond to an emotional question like that. Not enough time. Biggest reason for ineffective communication is just there's not enough time. Shared distress. I'm also distressed by what I'm seeing. And we sometimes forget that, medical professionals are also human, and they're around a lot of this distress. They're around a lot of trauma. We saw that in COVID. There was an epidemic of mental health issues across healthcare providers, because at some point that distress is going to be a heavy burden, a heavy cross to bear. Fear of blame. Someone mentioned that, they'll be afraid that they'll be blamed later. So they don't want to get into that place where they want to get into that whole shared decision-making space, and then giving the recommendations and so on and so forth, because later on the family will come back and say, but you told us to do this, and you said this is your recommendation. Okay. So fear of blame. And these are professional barriers, and also poor role modeling. It has never been modeled for us. The way the healthcare system was practiced earlier, You have grand rounds. Do you guys know what grand rounds are? Is when a senior doctor will lead a bunch of students through the ward, and they go and they see all the patients. There's a beautiful movie. It's called Wit. I'll share the link, and the whole team will go along, and they'll go and say, okay, what is wrong with this patient? And they say, this patient has this problem. Okay, all right. So what are the solutions? They talk about the patient. The patient becomes a case number. We're only talking about the disease. And then what do? Okay, so let's observe. And they'll remove the sheet and the patient is exposed. Changing a catheter in front of 15 strangers. Right? If you were to go to the toilet right now, just, for a bio break, you've not latched the door properly and someone walks in by mistake, what are you likely to feel? Embarrassed, maybe even angry, whatever, right? Such a small thing. It's an accident. Someone has accidentally done it. And imagine how dehumanizing it must be for a patient to be displayed with not so much as permission taken. Right? So we've not had good modeling, and therefore we don't know how to speak in humane terms. So we have a rule, and so in Pallium, what I've seen the nurses do is even when they are administering medication to an unconscious patient, they will talk to the patient. It's actually a beautiful thing. Because even if that person is unconscious, you're still treating them like a human being. Okay, so so that's not been modeled, and unfortunately, we learn from what we see, and if that's not been the case so far, then it's difficult to learn it now. Okay, attitude. I don't need to learn communication. Excuse me, I'm a cardiovascular surgeon. I don't have time for communication because I'm a cardiovascular surgeon. I'm sorry, I don't mean to attack cardiovascular surgeons. I'm just using that as an example because I was told that in the hierarchy of things, you have cardiovascular surgeons, neurosurgeons, cardiologists, oncologists, and then God, and then the rest of us. So that's what I heard growing up. Anyway, and the third is, I don't think it's important or relevant. As long as I can do that procedure and that surgery, and, I have a great success rate with my patients, what does it matter? I'm sitting and doing all this emotional communication stuff. I don't need to do it. That is a pervasive attitude even today. Barriers, environment, lack of privacy. Where in the corridors of an OPD are you going to sit and have a long conversation about eliciting someone's fears and needs? Physical barriers. I worked in a government hospital. We ran a pediatric palliative care unit there. And first of all, getting that OPD going for pediatric palliative care patients was a big deal. And walk into the room, and the room, 3/4 of the room is taken up by this humongous table. Huge. And if the children came to visit us, all of us would be seated in different parts of that same table, and then they'll come like that. The physicality of that room itself was a barrier. Eventually, we wanted that table out. It took us close to a year to get that table out because it's a government hospital. So you have to get permissions from various levels of authorities. And at least finally, we were able to create a play area. And when working with children, you need to have an area where they can relax and play. But it took us a very long time to get to that point. So for a non-Malayalam speaking person, my way of interacting with children was through play and through art. But I couldn't do that till we finally cleared that space up. So physical barriers, and also physical barriers like the lack of maybe a screen. Okay. Or it could even be, just the noise in the room. It could be it could be a noisy place. So all kinds of physical barriers. And those are things, unfortunately, we're not able to do much about. Noise distraction, like I said. Also constant ringing of the phone and being important, because you're constantly getting phone calls. Okay. There are also barriers that come from the side of the patients and their families. Fear of questioning professionals. Fear of questioning. I don't want to ask. Why don't I want to ask? One, because I'm scared. Two, I don't want to be that difficult patient who asks my doctor a lot of questions. Now, who are difficult patients? Difficult patients are people who challenge you, who come to you with other opinions, who've gone to the internet, and they said, but doctor, I read this there. Anyone who talks a lot back or expresses emotion is a difficult patient. I want to be a good patient. Fear of questioning also, because I don't want to sound stupid. It could be any number of things. Okay. Fear of death and dying. I don't want to have the conversation because it might lead to the fact that I'm actually not getting better. So let's all pretend that that elephant in the room is not there. And protection of others. And we will talk about this in the next session. Collusion. Collusion is when I tell the doctor, please don't tell my mother that she is sick. Please don't tell her that it is serious. Please tell her that she'll get fine. And we do this because a lot of the times what I hear is, I don't want to destroy her hope. Or there'll be other, in the same vein, there'll be other reasons like that. And in this attempt to protect the person, I gatekeep. This is exactly what that lady was doing for her husband and the daughter. She didn't want the daughter to talk to the husband because it would suddenly make the whole thing very real, that he's dying, because she wants to talk to him about getting the affairs in order, right? So there are barriers that come from the side of the patient and the families themselves. And there are social barriers. We as a society are a death-denying society. We don't want to talk about death. I mean, we don't want to talk about death. We don't want to talk about sex, but we are 1.4 billion people, 1.4 billion immortals. And, so we don't want to talk about these things. And it's considered abshagun, inauspicious. All of those things are there. Expectation of medical miracles. Your history is telling you that this is not working. Then someone somewhere will tell you that this one doctor had success with this one kind of patient. So we want to try that now, in the hope that we will also have that miracle. And we encourage these miracles as a society, we encourage it. There are cultural barriers. Some of the most common misunderstandings result from negative stereotyping. Women have a higher threshold for pain. It's okay. Women can bear pain better than men. Also, there's what is stigmatized. What kind of diseases are stigmatized? People don't want to talk about things. Why does India have such a huge prevalence of cervical cancer? 1/5 of the global burden, because it's something that affects a woman in her reproductive organs. We have vaccines that can prevent it. We can eradicate cervical cancer in 1 generation, but we don't want to talk about it. Okay, the other is that medicine in itself is a subculture. We have language to talk amongst ourselves into this echo chamber. And also, there are hierarchies and dynamics in the healthcare system. Palliative care is typically seen as an outlier, sorry. It is considered a soft science. It's considered, and then there's the profit margins. There's pharma, there's pharmaceutical, corporate capture. So there are lots of things that are going on within the healthcare system and the medical subsystem that is a barrier to itself. I mean, I don't like, the International Narcotics Control Board tells India how much poppy they can grow, what licenses should be issued to farmers, how much pain medication can come out of that. So it's the whole world that that requires intense navigation. Okay. Okay, this is an interesting question. Literacy is often considered a major barrier. Do you think literacy is a barrier to communication? The ability to read and write, do you think it is a barrier to communicate?
Sometimes, maybe they come with a lot of overdose of information that sometimes creates a barrier in communication because the other person is not in a position to listen to the therapist or the expert there. Sometimes, that creates a barrier and then they understand that, yeah, I know about this a lot.
But
I don't know.
The ability to read and write is a barrier to communication?
Okay.
A significant percentage of our population is unable to read and write. Yes, Indira, please.
I don't think it's a barrier to communication, simply because let's say the story you told us in an earlier class about the fisherman and Dr. Raj. I mean, here is Dr. Raj, who's so, educated. He's a doctor, well-known doctor, but he's obviously able to communicate with the fisherman and understand what his pain score is and see how that can be brought down. So I don't think, and especially when it comes to life, death, suffering, I don't think you need to read and write to know that. I think, basically people understand that this is suffering, this is pain. That's what I think.
Okay, thank you. Thanks for that. What if ये सुबह खाना है, ये दोपहर में खाना है, ये रात को खाना है? You have to take these medicines. The prescription, reading the prescription. What about navigating the signage in a hospital? Are there ways to overcome that?
Aren't there ways in which they draw? Doctors usually draw the number of tablets and morning, evening. So I've seen that in prescriptions.
Yeah.
So I think that too can be overcome. I mean, I don't think that is. Also, I feel that for those who are not literate, they need to remember much more. And they do remember that, at least culturally we see that. They're long songs they remember, they're long. So I think there are ways in which people function and we need to understand that. That is my sense.
Lovely. And I think so then the onus is on us to become better communicators. I saw this beautiful thing in a hospital in Nepal where you walk in and every door is a different color. Every department door is a different color. So you know that the diabetes is in the blue door. The pulmonology is the green door. So even when they're giving instructions to their loved ones, they're able to say, well, hara wala, come to that darwaza. So it is very much doable. I think someone had their hand up. I'm sorry if I missed it.
Yes, ma'am.
Yes.
So when I started to work, I mean, this is a very good idea in itself. However, when it comes to practical setting, I worked in a very rural area where I worked with very old people whose children are away for their wages and all. And the tablets that were given to them are for every 2 hours and they have to take it midnight also. So we as a team, when we went, there were so many times we have gone and we have told them this has to be taken. We tried all kinds of things. However, the patients used to miss tablets, both the couple, they both have the problem. So in a practical setting, even I felt like, what can we do for those kind of people who are living in area where they don't have anyone else to help them except the couple itself. So I guess the problem in itself is very much it's very much there, and in a very practical setting, I don't know how much we can help them and to what extent we can do.
Thank you, Kiran. No, I'm hearing you. And but so today's discussion about literacy, I just really wanted everyone to think about it a little bit, because I think the most important thing here is to remember that illiterate does not mean unintelligent. So it's really about finding the right, I mean, even talking to somebody who speaks only a different language. We have people who come from West Bengal to Trivandrum for treatment. How are we navigating that? So illiteracy is not to be confused with lack of intelligence, and really creative flyers, infographics. Now, what Kiran has talked about is a very serious practical issue. Elderly people living alone. Now, I don't have the answer to that right now, but that's food for all of us, food for thought. Okay, now communication skills can be learned. It's not that you have to be born with it, and this is an ongoing process. It has to continually be updated. And it's not what you say, but how you say it that has impact. Now, please understand something. I think people have had this 30.
Yeah.
Yeah.
I couldn't hear you for a bit.
Okay, can you hear me now?
Yes.
Okay. So I was saying that there's this common idea that body language is, 70% nonverbal, 30% what you say, etc. It's very important to remember that that applies to emotional communication. Okay? When you have to give information regarding disease and stuff, you can't do it with playing dumb charades. So your words are as important. The words that you use to describe an illness and a disease, I mean, to describe a disease, the trajectory, that's as important. But also when you're conveying, when someone is in distress, then these kind of percentages come into play. The tone of your voice, your body language, and the words. Okay? But not to be confused with information giving when it is factual information only. And I'm just going to take a few more minutes to go through the distancing behaviors, and we'll stop with this. And the next session, we will talk about the facilitatory behaviors. So distancing behaviors typically that we might subconsciously do. And I'll close the session with this particular question, but can you guys tell me a time that you did not feel comfortable or heard or understood by a healthcare provider? I'm going to request that it is a quick share. Just a time. You can tell me, I was in the hospital once and this is what the doctor said to me or whatever. This is how I was not received. Any experiences? Aparna?
Yeah, so okay, so because of my periods issues, I had to go to gynec multiple times. And it's like the moment you say that you have period issues, they are just ready with a prescription of birth control. They say, yeah, 23-day cycle, you do this, you do that. And it's like they don't even listen to the whole thing. And despite me saying that I'm not comfortable taking birth control because I've done this before, I don't want to do it again, they will just like, I don't know, change the brand name. But then the medicine would remain the same. So that was one of the times like I would be like disappointed, and it's like there is no point in talking to the healthcare professional if this is the same solution I'm going to get for all my problems.
So they choose to focus on the assumption, I mean, on the medication. They're not focusing on what your preference is.
Yeah, and like when I have clearly stated that this is not a medication I want, and so but they would continue just prescribing that, and then there would be like a whole time I have to like sit there and convince them that I know what this is and I don't want it. They will just take it that like, I don't know what I'm talking about.
A classic example of a difficult patient, Aparna. I'm joking. I'm talking from the healthcare. Oh, here comes Aparna again to tell us that she doesn't want medication. Yeah, but I hear you. That's and also sometimes with gynacs there is a little bit of judgment. Those kind of things happen. So thank you for sharing that with us. And some of the distancing behaviors that we see. Oops, sorry. I don't know why I keep doing this. Some of the distancing behaviors that we see quite commonly played out are things like this. What's going on? Eye contact is poor. They won't really maintain good eye contact. Facial expressions are usually unwelcoming and unfriendly. Tone of voice, either indifferent or impatient. Body position, very paternalistic. So sitting while the patient is standing over the patient's bed. So that power dynamic is very obvious in the positioning of the body. Okay. Body posture is negative. Arms across the chest, turned away. Attention is either distracted or busy. So looking, not making eye contact, constantly looking at the watch, signing other files while talking to you, things like that. And focus is on the physical. I don't want to hear your story. I don't want to hear about your preferences. You've come to me because you have this problem. I know how to fix the problem. So I'm going to focus on the medicines and the intervention. I really don't want to know about the rest of it. These are distancing behaviors. I'm distancing myself from you by employing all these tactics. Okay. And paying selective attention to safe physical symptoms. A patient says, doctor, I'm so worried. I can't sleep properly. I also have back pain. Tell me about the pain. Because I can give you some painkillers for that. No. If I start talking to you about why you can't sleep, then I'm going to be sitting here for the next half an hour listening to you and your financial problems, and then you're worried about your child. And I really don't want to hear all of that. So I'll fix your pain and I'll send you off. When I've done something, I've sorted out a big part of your problem. So I'm happy. I congratulate myself. You are partly satisfied and you leave, but we've not addressed the sleep issue. Saying stuff like, this is life, unfortunately, it's part of God's plan. Moralizing, I find that this whole healthcare system is very guilty of that. Guilt tripping patients. Oh, you smoked all your life. Of course, you have lung cancer. Asking leading questions. You're feeling better today, no? I have to answer you in a way that you want me to answer you when I lead you to a particular answer. False premature reassurance. Don't worry, it's all fine. It'll all be fine. Jollying along, where you just comment on, you try and be funny and you say, oh, Mrs. Sharma, you're looking a lot brighter today. Something must be working, and not actually letting Mrs. Sharma sit down and talk to me about maybe she has some concerns and worries. Using only jargon. I will stick to medical language. Okay, so I'm going to stop with this. We've covered a fair amount of ground, but we're only halfway through the communications module. So we will be discussing some tricky situations, but most importantly, we will be talking about how to deal with difficult conversations in the next session. So thank you for your time, and I will see you in a couple of days from now.
Thank you.
Thank you. Thanks.
Thank you.
Take good care, everyone.
Thank you, ma'am. Thank you for the session. And thank you all others for joining the session, and see you all in the next session. Yeah, bye. Take care.